Good. So good afternoon, everyone. We sort of met informally, but officially and formally. My name is Dr. Kitiboni Rolle-Adderley. I am a physiotherapist. I've been a physiotherapist for the last 25 years. And it's a pleasure to be here with you guys today. When I was asked to do a presentation, I asked, what subject matter do you want me to speak on? And it was very flattering for her to say, for Avis to say, talk about physiotherapy and your role in cancer rehab. Go to the next slide for me, please. So when you hear the word physiotherapy, what's the first thing that comes to your mind?
Exercise, therapy,
Recovery, exercise. What else?
healing.
I love that. Healing. Anybody else? You're all saying all the nice things. Some people say, well, it's be plenty pain, or they say exercise, but not in a good way. So yes, those words are very synonymous with physiotherapy. How I became a physiotherapist was, one, I had a cousin that graduated from physio school in England the same year I graduated from high school. And she came and she spent the summer with me. And I just listened to her talk about the body and physiotherapy for the couple of weeks that she was here, and that was it. The good thing is that half of the job was already done, because as a graduate from high school, I had already applied and been accepted into COB. Yes, I'm that old. In the biochemistry program. And so I didn't have to do any shifting. I just had to learn to appreciate and understand what physiotherapy is. And I've never changed my mind. Never. So from 1992 till now, I have been convicted to this profession, and I absolutely love it. What caused me to venture into cancer rehab, you can go to the next slide, please, is as a young physio, when I graduated from school, I was in the hospital system working. And I would go on the floor, and there would be patients sitting or laying in bed with abnormally large abdomens and legs and arms. And everything that I was taught in physio school did not work. So I felt like a failure. Remember, I'm a young PT now, so you already feel like you don't know what you're doing, right? I felt like a failure, but more importantly, I felt like I wasn't doing enough to help the people that were in that situation. And so I used to ask the doctors, what is this thing? And they'd be like, well, that's and it wasn't even, they didn't even say lymphedema at the time. That's just a side effect from the cancer treatment, right? Remember now, this is in 2001. And I said, what do you mean a side effect? So why can't we do anything about it? And he's like, don't worry about it. At least they're alive and the cancer look like it's going. Are we doing the treatment? Let's see what happens after the treatment. And I was just like, this makes no sense to me. So eventually I started to do the research. Not eventually, it didn't take me long to start researching, and I realized that this thing was lymphedema. I was just so upset at the fact that most of the survivors had come through the worst of the cancer treatment, and now they're left with this large limb, and nobody's doing anything about it. It wasn't fair. I believe I had to fix it. Found some courses, went off to the States, 14 days. It was a 14-day course to become a certified lymphedema therapist. So forgive me when I get a little upset when other people do a 2-day course and come back and talk about they doing lymphedema therapy, because that's not it, okay? So we had a 14-day course. We had to do the theory and we had to do the practical, and the practical meant everything that I now do to you was done to me, and I had to do it to my colleagues. We had to get it right. They would check the quality of our bandages. They would check the way we spoke. They would check our explanation. They trained us to come out there and be advocates for cancer rehab, therapists for lymphedema. And this is how I really got entrenched in oncology rehab, because as I came home and I started to treat patients that showed with lymphedema, they came with all the other side effects of cancer: the neuropathy, scar tissue, mental fatigue, physical fatigue, pain, weakness, depression, anxiety, frustration, fear. That didn't sound like physical therapy, right? No. But all of those things, if I wanted to show up in the best way for my patients and really help my patients, I had to arm myself with the skill sets and the tools to help them at least get to a particular point. And if it's out of my scope of practice, or it's a bit too much for me, then I know who the credible sources are for me to refer them to. Sometimes the pastors that we go to do not have the skill sets. We call a friend or we call a fellow survivor. Her story is not your story. And so we had to make sure that we created a pool of resources, a pool of clinicians that we can refer to when these situations came in. And I've been very, very dedicated to that cause. So I really want to emphasize that we are licensed healthcare professionals focused on restoring movement, function, and quality of life, right? Now, what impedes your movement and your function, your quality of life? Pain, neuropathy, weakness, swelling, scar tissue, mobility, balance issues.
Yes, balance.
Right? We forget that. We hide that. We don't talk about it. It's just easy to say, well, that's what happened with age. What you expect? Well, that's what happened because it's a side effect of chemotherapy, right? All right. And so, this is what we do. We assess it, find out the cause of it, and then we treat it. You're fine, great. Okay, so the spectrum is vast. I often get questions, what's the difference between you and a chiropractor, you and a massage therapist? There's a big difference. There's a massive difference. One of the biggest differences is that the spectrum of care we give. I have a colleague who is a chiropractor, and he says, oh, well, we treat babies too. I'm like, yeah, but you're just adjusting spines. I'm in there when that child is born, making sure that child has proper tone, and tone is able to hold up their head, right? If a baby doesn't hold up their head at a particular time, something's wrong, right? If a baby doesn't stand and walk, that's more than cracking the spine and aligning the spine. I'm in there doing that. But I'm also at the end of life, if we want to call it that, because end of life could be any second for any of us, right? But I'm also at the end of life doing palliative care, making sure that my seniors maintain as much independence as possible, regardless if they've had strokes, amputations. So we work across the length and breadth. We show up in the workplace. We show up sports teams, you see us, right? So when you think physiotherapy, I don't want you to just think exercise. I just want you to understand the spectrum of what it is. Now, I am a weird physical therapist, and weird meaning I'm a nerd. The more I don't know, the more I want to know. So I've gone and done a lot of studies and a lot of training, because every time I figure out something, it attracts something else, and then I realize I need to sharpen my skills because I didn't know enough about that. So I say that to say that in the American Physical Therapy Association, there are 14 sections. We have women's health, we have geriatrics, we have veteran affairs, we have equine therapy. So we have therapists that just deal with horses, equine. We have canine therapists who just deal with dogs, okay? There's pediatrics, there's cardiovascular health, there is women's health, right? Because we just do more than give birth. We still have uteruses and vaginas afterwards. And Lord, menopause is a walk. Perimenopause, because sometimes I look at my mommy and like, you ain't tell me all this was coming, right? And I think I'm doing very well, right? But we come from a time when we didn't talk about a lot of these things openly. We weren't allowed to say vagina and Bahamian vernacular, your crabby ain't working, right? And you still check like, but we need to have these conversations, and especially in populations where we have therapies that change the way our sexual organs function, right? Okay, so right across that spectrum, chronic pain, orthopedic recovery. Everybody know me because, you have a broke back or a sprained ankle or your knee hurting. We're more than just orthopedics. Seniors, aging in place, geriatric care is the big thing, because guess what? A lot of us are over 55, a lot of us are over 60, a lot of us are over 65. What happens is we get older, sometimes we get more diseases, more conditions, and so we need specialized training for that. Because remember, one of my goals is to improve your quality of life. I don't care how much you have left, that is not my call to make. But whatever you have, I will make sure that you will enjoy that to the fullest, okay? So then we have specialty. Oncology rehab is a section. That's the section that I proudly belong to. I'm so grateful for that. They kept me sane, because you'd be surprised at things that pop up once you start putting yourself in a situation. And I'm like phoning a friend. I was like, girl, this patient just walked in here and I don't know what to do. right? Or this patient comes in and they don't have the funds. What do I do in the meantime? And so we have this beautiful section of people. And to work in oncology, you have to be very caring and very giving because it's emotionally taxing, right? And so I have a network of friends that have just dedicated themselves to knowledge. So, and we love to show off. When I say we, they love to tell me all they're doing is research. And so I'm never at a loss of access to information, credible, resourced, researched information. So we also do women's health, neurology, cardiopulmonary, the way our heart and lungs are functioning. Right? We all have little issues, hypertension, hypertension, thyroid issues. If you had radiation on your chest wall, that's a compromise. Chemotherapy can be cardiotoxic. So these are the kinds of conversations we have, and this is why we delve. So that is how physiotherapy shows up for people living with cancer or who have had a cancer diagnosis. Next slide, please. All right, so let's get this myth out of the way. Yes, we do exercise, but exercise builds the strength and the fitness aspect of it. It also does endurance and it does flexibility. But what the difference is when we talk about exercise and physiotherapy, it's very specific. We call it supervised exercise therapy or therapeutic exercise, meaning that we are going to pick exercises that are going to target and treat a condition, a disease, or something that you're presenting with. So yes, you can go online and you can Google. There's some great ones. YouTube is being bombarded with it right now. But you have to make sure that that is appropriate for you, because not all exercises are appropriate at a particular period of time. It's recovery focused and targeted to treat comorbidities, right? So exercise is just one of the tools that I use as a physiotherapist. There's so many other tools, and I'll introduce you to some of those today. But exercise is also prescription. So in my profession, I should have put a picture here, you often see a prescription pad, and they go RX, the treatment, exercise. And so no, it's not jumping jacks. No, it's not walking in place, because I can't ask somebody who has balance issues to jump and jack, right? I can't ask somebody who may have had breast cancer surgery and still have scar tissue to raise their hand over the head. I have to meet with you. I have to do a very thorough assessment and then decide what is the best intervention for you. I don't like to use the word treatment. I love the word intervention. They're basically the same, but intervention makes me feel a little bit more proactive. Intervention means that you're a part of this journey, right? Because if I'm doing all the work with treatment, but intervention, you're showing up and you're meeting me and we're working together. Any questions so far? What questions do you have for me?
I have a question. You mentioned exercising. I know you don't do exercise, right? But once you have the...
You failed the first test? What you mean I don't exercise?
I mean, you say, not to be like going to the gym and stuff like that, right? So, is it a problem to, like, the surgeon to lift your hand over your head after surgery, or do you have to wait a certain length of time?
It depends.
Okay.
It depends, because when you say, if I have to wait after do a certain length of time of surgery, I'm going to ask you what surgery you had. Which surgery?
Breast surgery.
Which breast surgery?
I had bilateral.
Bilateral mastectomy.
Yes.
Was there any muscle tissue involved?
I don't recall.
Were there lymph nodes taken?
Yes.
Any radiation to the area?
No.
Okay, so do you see how my line of questioning goes? Because your breast surgery will not be somebody else's breast surgery. So we don't just say, okay, what we're going to do is a cup of this, a cup of that, and go, right? So if you've had a lumpectomy, which is also a mastectomy, but we call it a partial mastectomy, right? That's going to be a little different than if you had a total or radical mastectomy. Good? There are some times that by the time the cancer is isolated or found, there is also muscle tissue that's been removed. So instead of just having breast tissue removed, sometimes we have to go a little deeper and remove some of that muscle tissue. You are not going to get the same exercise protocol just having, and I don't want to say just because it's not trivial, by removing the breast tissue if you've also had muscle tissue removed. You see? So this is, It's nitty because how long are your drains in, right? Are you diabetic? What other comorbidities do you have? These are the kinds of things, and comorbidities might be if you were anemic, right? If you already had issues with poor healing, if you've had an old fracture site that nobody talked about.
Okay.
These are the kinds of things. Did you go into surgery with an injury before? Because I'd be like, okay, in 3 weeks, I want you to take your hand over your head. And you'd be like, well, I ain't had my hand over my head for the last 3 years, because nobody had that conversation of what that movement looked like before. And now you frustrated because I asked you to do something that you weren't supposed to do. You too ashamed to tell me that you didn't have it, or there may be so much going on, you don't even remember that. So it is very, very specific to the person that's in front of me. Yes, I can give you a 1, 2, 3 recipe. You make Kool-Aid, 2 limes, a lemon. But if you're diabetic, I don't need you to put 2 cups of sugar, put 1 cup. So you understand? Okay. All right. Make sense? Good stuff. All right. So, yes.
Sorry, you were asking if we had any questions.
Yes.
Can you explain lymphedema, please?
Certainly. We're going to get so much deeper into that. But lymphedema is an abnormal accumulation of fluid in a body, okay, in a particular part of the body or the whole body. In the conversation for people with the diagnosis of cancer, what usually happens is, one, cancer cells are moved throughout the body via the lymphatic system. That's one of the ways. This is why when you are tested positive, and you've tested positive for cancer, what we tend to do, or we, the medical fraternity, is going to look at the lymph nodes closest to the site that your cancer manifested in. And how do they look at their lymph nodes? How do they look at the lymph nodes? And what's the biopsy? Invasive cutting surgery, but what do? They take the lymph nodes out. Right. So I need you to stick right here. They took the lymph nodes out. So if they took your lymph nodes out, your lymph nodes are sort of like the pump system. So you've removed some of the lymph nodes, which means that your body has lost the original capacity of moving lymphatic fluid. So the fluid is going to go in through the blood. That's what happens. Most of it comes back out as blood, but there's a small percentage that stays, becomes lymphatic fluid, and the lymphatic system is responsible for moving that fluid. If you've damaged the lymphatic system, the fluid's not going to flow. And so what happens is that the rate is going in at 2 miles per hour, but now it's leaving at 1 mile per hour. So what you will find is there's going to be a buildup. If there's been a lot of lymph nodes removed, if this person is not doing the things that they could do to improve lymphatic flow, which looks like exercise, which looks like compression, looks like breathing, it looks like moving. And that's what happens. So sometimes it's very obvious for women who have had breast cancer, and depending on the surgery that they've had, the biopsy, which is also surgery, but we don't even think about it sometimes because that can cause a lot of pain and complications afterwards, all right? And it'd be, that's all right, that's a small cut, you get over it. That's the things my oncologists say. And that becomes an issue. And so we need to have those conversations. We need to talk about it. If you start to see fluid build up, if your arm starts to feel heavy. With men, prostate cancer, sometimes they get the swelling in their scrotum. Oh, child, they didn't prepare me for that one. So you get there and there's a scrotum about the size of a basketball. And I got to decompress that scrotum. So I'm having a conversation whilst I'm holding the scrotum and trying to wrap it and massage it to get that fluid out. If you had to tell me I had to go into school to massage balls, I'd tell you a lie. But that's what it is, right? Okay, so that's lymphedema. But we're going to delve a little bit more into it. I want to make sure that that's one of the things that you leave here knowing, all right? Because you can also have abnormal swelling from poor circulation. Poor circulation can come along from hypertension, cardiovascular disease, diabetes, sometimes aging, sometimes sitting too long, increased weight. So at least I want you to be able to identify it, phone a friend, me, or somebody else when you see it happen, and look out for other people when you see it happen so we can step on top of it. All right? Any other questions? Good. All right. So Pain and stiffness post-surgery and radiation. Pain. It is unbelievable the amount of pain that we walk around with. And I say we because I'm guilty of it as well. I was just telling Dr. Sai, Dr. Sai, I know I need to get this fixed, but the physical therapist in me knows that pain is self-limiting, meaning that it's going to go away eventually. The pain goes away, or you know what happens? We accommodate to it. And this is why I tell us, a lot of us wake up dead because the body been telling us pain, 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 pain. We ignore. And we just keep raising our threshold, not paying attention. The body was given pain as a signal to say stop and check because something is wrong. So if you are painful for prolonged periods of time, please figure out what it is. Okay? Don't walk and carry that. Heart disease is the #1 killer of women. And sometimes the heart is giving us signals, but you know what it is? Girl, it's gas, shall I eat? It's gas. Or you know what it is? These people at work, they stress me, or they always just raise my blood pressure. I get this little headache right here. Right now I've been clenching my jaw, and I get this pain running down my arm, but I'm asleep. All of those were signs of heart attack, and we don't recognize it. And we go to sleep, and we wake up dead. And they'd be like, but she was healthy, what was wrong with her? But all the time, the signs were glaring. Yes, ma'am?
I'm glad you brought that up because we lost a very good friend at 51
Mm-hmm.
on March.
Yeah.
Putting herself for gas. I got gas pain and she kept
Drinking all kind of Maalox and Pepto-Bismol and...
until 2 o'clock one morning. It was so bad she had to go to A&E. And by 3 o'clock she had the first heart attack. They brought her through. 5:30, 6 o'clock, my brain was gone because we are very, very close. Kids grew up together. So that is just has stuck to me. Don't take it for granted. Because so many people say, I got gas, just drink some hot tea. Check it out. Because even when we don't have the same symptoms as men for heart attack, we get tightness in the neck. I don't want to take it.
No. I like the reinforcement.
Yeah, we have shoulder pains. We get nausea. Vomiting sometimes, you sweat, and you just feel extremely tired. And our pain is not like this. It could be any part, but you know that something isn't right. So we always say, don't wait until you get left or right arm.
It could be either way.
Men are different. They get the heart attacks differently. Bam, it's more specific, but we women, God didn't make us like that.
That's right.
So you have to decide now, let them find out what it is, because our symptoms are different. And as Kitty is saying, you can take anything today. Our heart attacks, especially chronic disease, is different. So be mindful of that.
Okay. Especially if you had chemotherapy too, because chemotherapy is cardiotoxic.
Yeah.
All right, it is toxic to the heart. Outside all the stress you have, because if you have children and a partner and a job, you're taking care of older parents, you're taking care of younger children, and then you're worrying about everybody else have to say, we picking up too much stress. You got to learn how to cut that loose. Don't mind if they think you crazy. Be crazy with low blood pressure and no stress. Let them have the stress, worrying what's wrong with you. But you do a very good job of properly maintaining your stress and weeding out, putting out barriers, right?
Right.
Good. All right. Somebody had a hand up just now? Sorry.
That was me.
Okay.
I wanted to add, I know before I went into start chemo, they normally have you do a heart test.
Right.
Yeah, and when you said it just now, it just reminded me, when she did my test,
Right.
and she looked at me and she said, you have the heart of a 13-year-old. I said, really? I said, thank you, Lord.
Right. What were those numbers? That's one of our greatest faults. We spend hundreds of dollars on tests and cannot give the numbers. If you have a test, you want your results as soon as possible. You email those. You email those to yourself and to your family member or trusted friend. Okay? Don't just put it in your phone because your phone could crash like mine. Email it to yourself. So the next time somebody says, so what was your heart test? You could go into your email account and say heart test, and it pops up. Because one of the things I do ask my patients, so are you hypertensive? Yeah, but I have the gut hypertension. I ain't too bad. What's too bad? Well, I know, you have the high hypertension, and then you have the low hypertension.
I thought it was
What is that? What is that? Okay? So my blood pressure is usually 107 over, what is it? 107 over 70, right? Which was considered a little low, but now they're calling it more on the normal side. When I get headaches, 9 times out of 10, I'm probably a little stressed. I could get a headache at 135 over 80, right? My mom's very vigilant with that because I think we've had enough experiences in our family and she's seen enough. She panics when that happens because I don't complain a lot. So I remember once I went into the doctor's office and it was like 130 over something. No, it was 125 over 80. And I say, you know what, Herb, let me go home because I need to rest. My pressure high. Kiki, your pressure high. Miss, my pressure's be 110 over 70. My pressure high and you raising it. So she's looking at me like I'm crazy, but I'm normally a very low blood pressure person. So when my pressure starts to rise, I feel it a lot more, right? Imagine the person now whose blood pressure is always teetering right at that borderline, 138, 140, 150, and you just keep conditioning yourself to stay high. You might come home, you say you're like 148 all the time, and then you come in into me and I check your blood pressure and it's 145, and I'm like, this is a little high, and you'd be like, well, this ain't really high, you know, this might normal. Then we could have a conversation. If you come in and I say your blood pressure is 160, it's a little high. You might be like, well, it's a little higher than 140. I need you to have intelligent, well-informed, educated conversations of what your blood pressure is supposed to be. I don't know what a little high is. Don't tell me it's all right. Especially if you went and spent over $100 to a clinician, you need to know every number coming out. And they should be able to give it to you. All right? That's what you're taking out of this conversation. Yes, ma'am.
And I know I have low blood pressure.
Yes.
My blood pressure is like sometimes 92 over 64.
Okay.
And it's been that way for a long time. But I mean, I don't feel any different from it, no weakness or.
Because that's your normal.
Yeah.
Mhm.
So, you know, sometimes I say, you know, should you eat salt to bring it up or, you know, but yeah, I'm hypotensive.
Okay.
So,
All right.
but that's not too low, and that's not, I mean, 92 over, say 64.
Is that your normal?
Yeah.
And you don't have any ill feelings or anything like that? So what I would say to you is just keep monitoring it.
Yeah, I take my blood pressure.
Monitor
at the
it
same
and
time.
monitor the way you feel. Okay? You've had this body far longer than I've known your body. So you are the best person to tell me what's going on. But then what I love about it is that you're aware. You can say to me, it's been like this all my life. So you've paid attention. Some people, you ask what their blood pressure is, and they're like, well, it's all right. Every time I go get it, check at the screening, it's all right. They have 6 doctors. They don't want to pay for a blood pressure screening, so they go to the free blood pressure screening, whose machine may not be well calibrated. That's another conversation, right? Because if this machine been taking blood pressure all day, it might be a little off.
Yeah.
And we're supposed to change our machines out over time. You think we're doing that?
Well, I take it every day.
Good.
7:30.
Good.
I log what pressure is and the time.
With the same machine.
Same machine.
Perfect.
And so I keep track of it every day.
Perfect. You cannot monitor what you do not measure. Okay? All right. So, pain and stiffness, post-surgery, and radiation. I don't know if that applies to anybody in here. Somebody talked about neuropathy, tingling and balance issues secondary to chemotherapy. Also, diabetes can present with neuropathy. Sometimes chemotherapy can cause our bodies to freak out and throw us into diabetes and metabolic disorders. So which came first, the chicken or the egg? Because you may have a little bit of diabetes too, right? So what was your last HbA1c? What that is?
I oftentimes get a
Good.
Yeah.
But do you know how many people?
I'm not diabetic.
Good. But when you come to me, that's the conversation I have first before I say, yeah, child, it's a chemotherapy to get you numb. No, because I don't want to miss anything. You know how much people do not know what a HbA1c is? You know how much people do not understand that diabetes or numbness and tingling could be a sign of diabetes? And it almost has the same presentation. So I've been working with cancer patients so long that I realized that a lot of the signs and symptoms of uncontrolled diabetes looks just like cancer. The mechanism of injury is different, meaning cancer, the signs and symptoms you see from diabetes is because the sugars damage the blood vessels and the veins, but it shows up just the same as the same nerves that have been damaged from the chemotherapy. So the treatment often is the same, but the care is a little different. The interventions are a little different, right? Because the treatment could be the exercises, but the intervention is, listen now, we need you to cut down on the sugar, right? We need you to do a little bit more of this versus a little bit more of that, right? So I just wanted to pull that out. And this is why you just can't go to everybody who will not ask you the questions. Sometimes the patient will be like, well, the only thing you want to ask me about my bra size. Yes, so what is your bra size? Is it the same size that you had after the surgery? Because if it's grown, then we need to check something out. No, I am literally that person. I'm literally that person. I ask you, when was your last period?
Right.
Girl, I can't remember. Okay, good. Patient is not seeing period. Can't remember. It's 2 years, 3 years, 4 months to let me know. Well, okay, for the last 2 years, I've been seeing my period. Okay, so patient may be in menopause. You come into me next month and you say, girl, Dr. Kitty, I see my period. But what we need to do right now is go and get a pap smear.
Yeah, that's right.
Because that is a sign of uterine or ovarian cancer.
Cancer.
You see how these questions are so important?
Yes, ma'am.
So I can be all up in your business. All in your business. Betwixt and between. Good. All right? So don't lie to your healthcare providers. Don't think anything is insignificant. Okay. Fatigue and weakness. You're tired. Did it just come from the radiation treatment? Did it just come from the chemotherapy? Mentally, are you tired? What all are you trying to manage? How are you trying to stay sane? Because that keeps you tired. Who do you have sucking your energy?
That's the question.
What are you hiding? What are you avoiding? Because the energy you take to hide and the energy you take to avoid certain things is energy that you could be putting into your body for wellness and giving yourself more energy to bring that fatigue. All right, my mommy itching. What's your food like? What are you eating? Right? So that's after, the license that's after, but that's part of it. But do you see many things we did before we got to the food? Because now the food is an intervention as well, but I need you to start paying attention to what's happening, because if you could eat all the food you want, but if you're still not doing what you're supposed to do for yourself, you will still be fatigued, right? Not saying that one is better than the other, but we have to approach this holistically. All right. You're tired too because you're not doing anything. The more you exercise, the more energetic you feel. Why are you not exercising? Dr. Kitty, when I exercise, I feel lightheaded. And then they don't tell me something wrong with my heart. So when I exercise, my heart start doing this. And then I get scared. And then Dr. Kitty, my balance off, so I scared because I want to walk and fall down. And then Dr. Kitty, the last person who I exercise with, give me so much pain, I scared to exercise. And then I don't feel right because I only have one breast. So when I exercise, the breasts feel funny.
Excuses.
No, but this is what it is. But you remember what my role is. My role is to make sure you function at your maximum.
Yes.
So then what we do is we take all of those excuses and we find ways and solutions to make sure that you show up as your best self for your best self. I don't ever laugh at a patient. I laugh with you.
Right.
But I will never laugh at you because it's serious. People don't want to go to the gym because they feel, they're always looking to see which breast I take off.
Doesn't matter, who cares?
For some people, it's a big thing.
It's a big, I know.
I had a patient who went and got her breast, the implant. She was not a good candidate for it. When she asked me about it, I said, let's do the research. Because in my heart of heart, it was a flat no. But I was like, let's do the research. We did the research. I said, let's go to the cosmetic surgery places and see what they say. And you know what they said? Radiation does not make you a good candidate for implants. But the doctor said he can do it. He can say that. Because at the end of it, your co-payment was $20,000. So how much do you think he pocketed?
Okay.
And do you think he cares that in the next 2 or 3 years, your implants start coming up underneath your throat?
Right, no.
If you have a reoccurrence and we got to cut that out again. You see?
It's no.
I don't say no. Let's do the
I mean, I
research.
say, for me.
Right. Now, and this is very personal, this is my personal opinion, but this is my personal opinion from 21 years of experience. Because I can't tell you how much women I've treated to try and get the implant down. And you know when I really realized that? When I did my first set of training in rehab, the second year I went back, the person who hosted it, I said, could I spend a week in your clinic? I want to shadow you in the clinic. In Georgia, very highfalutin, a lot of the rich white women. And when those women started taking off their clothes, I was like, what in the Frankenstein is this? Because they're paying for all these elaborate surgeries. They were getting the flap where they're pulling the abdominal muscle and flipping it upside down. And they was taking the muscle from here and pulling it through and flipping it. And then they was having an implant. That's just how my face was. And I had to say, give me 1 second. I need to come back out. I said, okay, breathe, kitty, breathe, 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 breathe. Because my mommy always says, you're very expressive. I didn't buy that my daddy like this, right? So I was just like, what? Now my training is manual therapy. So when I saw that breast, I was like, okay, hold on. Now this is the funny thing, and this is where culture becomes very important. And I'm so happy that I was born where I was born, because we like to touch people. Like, you don't feel no way when I said, girl, you all right? In the States, you can't do that. First of all, you said, is it okay if I touch you?
Yeah.
Right? We don't do that not. But and you don't feel any kind of way, mostly, right? Okay. When I saw those women, I was like, okay, we got to hold this and we got to touch this and we got to move this. And I just said, may I touch you? And she's like, well, I don't know what you can do. It's called encapsulated, because the fascia, and let me tell you what the fascia is. You ever clean chicken? And you take the skin off the chicken. There's a shiny film that looks just like this. That's your fascia. And what fascia is this connective tissue that wraps around every muscle, vein, nerve, and structure in your body. It makes up your ligaments and tendons, right? So when the fascia gets tight, I can hold you 1 second? So when the fascia gets tight, let's say we took the breast, right? Or it's radiated. The fascia gets tight and it does this. Look at how a shirt's pulling. Okay? So this is somebody who's going to complain about pain across the chest, especially in that area. And then you think her arm is going to move properly?
No.
And if I ask her to take a deep breath, because the fascia has a lockdown. Okay? So that's what we were seeing. And I asked my coach, my mentor, and I was like, she's like, go ahead. Now, you know, in the States, you're not supposed to touch nobody. You need to be licensed to the Kahoot, right? But she allowed me to touch. And then I went in there and I did something called myofascial release, and I started to move. And we got some good results, and there was some decrease in pain. And my other colleagues, because they don't practice like that, I'm very hands-on-y. They weren't very hands-on-y. They didn't feel comfortable enough. They started to touch their patients, and the patients got results. But just think how many women had passed through and who are living with all of that. Now, when you see them out and they like this in the air, but the pain and the disfigurement that they go through. Now, it's not everybody, right? It's not everybody, because you have some good results. People who may have been radiated before and don't show those things. But there is a high percentage that will manifest like that. When we get into menopause and we lose our estrogen, we also lose our pliability and flexibility. So if you've had this intervention done in your early 40s, as you slide into 50 and 60 and things start to haul up, and you'd be like, well, I never had this problem before. All of a sudden, because your body is changing, hormones are affecting your body. You are not just that person who had that. This body is going to carry you through the spectrum of life. And this is why your physiotherapist rides with you the entire time. I can tell you I'm being very humble now, walking through my own valley of perimenopause. I'd be like, oh, I missed some stuff. Because I was thinking very orthopedically. As a very young therapist who did not have access to this information or this experience, but now I'm bringing that in. And because I work with women who were medically pushed into menopause, I saw a lot of this before. And so that sort of gave me the sharp skills, but it still didn't prepare me for when I had to walk through mine, or as I'm walking through mine. So all of those things come into, so you see how much time I took with scar and fibrosis, right? I ask you to take a deep breath. You can't move because that's locked down. So now we got to go in there and we got to break up that fibrotic tissue. And guess what? We call fibrosis the gift that keeps giving. 5 and 7 years later after radiation, we realize that it starts to get tighter. It may be due to menopause, or it just may be due to the way the cells behave after they keep dividing and separating. So we talked a bit about lymphedema, and then the fear of movement and the loss of confidence.
So could you, with the imbalance,
Mm-hmm.
because most of the time I walk and I feel like instead of me going straight in, I'm going either left or right.
Right.
And I find myself a lot of times just going in the wrong direction sometimes. Is there anything that could be done
Definitely.
about that?
Definitely. Definitely. So we do balance assessments, and then we figure out where the challenge is. So balance is a very beautiful skill we have. Balance encompasses muscle strength, vision, and inner air. Also joint sense, something called proprioception. And so what happens, we talked about the neuropathy from chemotherapy. It affects your inner ear nerves. It can affect your inner ear nerves, but it also affects the nerves in your feet. It affects your joint sense. And so you're off. The body is beautiful. The body will find a way to do anything it needs to do. Don't care how abnormal it looks. This is why we limp and walk all crazy, because your body knows you need to move, and we're going to move the best way we know how, right? So you may be going in the other direction because your body doesn't feel good on this side, but it has to get you there. What happens if you don't correct it and modify it? It becomes standard practice, and then that gives you more issues. So one of my questions in my clinic, have you fallen in the last 12 months? Well, I really fall, but I remember one time when I had to hold on. You know what a fall is in physical therapy? Anytime you end up lower than where you are is a fall. So if I'm walking and I do this, I've fallen. Because if the chair wasn't here, where would I have been?
I slept in the past, like a month or two ago. I was exercising and we had to do some laps and water was on the floor and I slipped. I slide, but I caught up on this knee and so yeah.
The knee needs some love.
Yes.
Okay, we got that. We got that.
If you're walking and you feel dizzy, but you have to hold on to a wall for a second, just to regain your balance, is that considered just dizziness, or is that fall under the category of falling?
Both.
Okay.
Both. We ain't picky, you know. That's some of us to fix. So we need to figure out, why were you dizzy? Did you eat that morning? Right? What was your blood sugar levels like? Because as much as it can be high, it can be low.
Yeah.
Right. No, when I was going through my process and I did chemo and all of that stuff, I had a lot of that. And actually, there was one time where it was just whoop. I don't remember what happened. All I remember is a big brown. And when I came to, I was on the floor. I was like, what? And I got up. And I was in the house with two younger kids. So, and when I came to and I got up, like they ran to me and asked, is everything okay? Are you okay? And I said, yes. But I just took it as what they told me what happened, neuropathy and loss of balance and all that stuff. But it only happened once, the fall. But I did experience that where I had to stop and hold on, because it was like I felt like,
Very lightheaded.
yeah.
So one of the things we did not discuss yet, which is also one of the things that we see as we go through cancer treatment, is anemia. Anemia, one, because we're women, and if you're still seeing your period, you're losing an excessive amount of blood. I shouldn't say excessive amount of blood, but you're losing blood. But also, because of the treatments, it also affects your red blood cell production, and it can make you anemic. Anemic, but this is for fatigue part right now. So for the anemia, that can make you fatigue as well, right? Low energy as well. I forgot that part about it. So you see, there's so many different little tiles that make up the whole picture that we need to pay attention to. We can't just say, well, you can get over it. That's just something you experience. Why am I experiencing it? Because why is she going through this with no issue and then I getting lightheaded, right? Why am I having numbness and tingling and this other person has nothing? We need to figure it out. because we don't fit a cookie cutter. There are things that our body might be telling us we need to pay attention to. And don't feel bad about it.
No.
Be grateful that you found out about it before something crucial happened, right? Okay. So what I really wanted to show here was the fear of movement, because the doctors always tell the patients, well, you just need to exercise. Just go do some exercise. You know, this is exercise 38 minutes a day. But the patient is like, listen, I don't feel lightheaded and fall out in the house with 2 children again. I don't want to slip, because obviously that exercise or the place I exercise may not be the best place for me. I can't feel my feet. I have pain in my knee. My blood pressure is too low. I don't like the way my heart is racing. And this is why my patients don't exercise, because they don't feel safe and comfortable to exercise. And then they come with a personal trainer. Okay, we can do this. Let's do this. Mind you, cancel and gone. Let's do this. Let's do it. And they have them doing all kind of crazy stuff. The patient gets hurt, and they're petrified to exercise again. And they're not moving. And they're not moving, they're not exercising. And all of the research is showing if you want to be healthier, you have to move. So we need to break that cycle. So what's stopping the exercising? Is it the fear? Is it the swelling? Is it the scar tissue? Is it the fatigue and weakness? Is it the neuropathy? Is it the pain and stiffness and surgery? Right? So even if physiotherapy was just exercise, there's a lot of work for me to do. And your therapist should be talking to you about this like this. All right, next slide for me, please. Okay, so rehab for treatment begins. Rehab before treatment begins. Oh, that's prehabilitation. All right, so you remember when I said, you asked me, do I raise my hand up after surgery? And I said, well, suppose you never was able to raise your hand up, right? So a lot of women are diagnosed with breast cancer, and forgive me for using breast cancer, because I don't know the different presentations that we have in the room, but I'm speaking from that because that's where a lot of my training comes from. And it's not to say that I don't treat other cancers, but you know why breast cancer is so tender to me? Because this arm is your most functional unit, and this is where you see most of the deficits. Because if you can't brush your teeth, take care of yourself, move, breathe, we have issues. And so this is where a lot of our focus goes in rehab training, because we realize that so many people are impacted by this. If it was Hodgkin's lymphoma, it would still have been the radiation in the chest. So I don't want you to think I'm biased, and I'm not considering all things. Okay, all right. So prehabilitation is something that we're trying to promote. So what that means is survivorship begins at, when does survivorship begin? When do you become a survivor? No. No, when do you diagnosis.
Okay.
The minute they say, this is what we found, you are now a survivor. So we go into, pardon?
Oh.
Activity.
Oh, really? At 2:30, we've been here an hour?
Yeah,
No, we started late.
we started late.
Okay, all right. So, okay. So 5 minutes, I'll wrap this up in 5, and we just have to come back to it later on. Okay, so with this now, right? So we do an assessment. We see how the arms move. We see what your heart rate is, your blood pressure is. We see what your balance is. I get baseline measurements, and with those baseline measurements, I know where you should not be below, because from here is only up. And so prehabilitation is a good way for us to meet, know what your specific needs are. So when these things start to manifest, I already have you. I know what to expect, and I know what to work against. Click for me. All right, and then prospective surveillance. This is after treatment. So what we do is, depending on how far out of treatment you are, if it's in the first 2 years, we usually go every 3 months. After the 3rd year, we go every 6 months. And then after the 4th or 5th year, we go every year. And those same assessments are done. And we do that to make sure we keep you at that same level or higher. And if things change, we'll be able to identify it. So we're checking the stiffness and neuropathy, the swelling. We're catching it early. Okay? Boom, 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 boom. Prevents long-term disability. Interventions. Any questions about those last two slides? All right, next slide. Good. All right, so I think we talked in depth about that. These are signals that your body needs support, and this is what we're here for. Next slide for me, please. All right, so this is what we call a physical therapy assessment. The TUG is a time up and go. And what a time up and go is that we have you sitting down in a chair. I said, okay, when I say go, I want you to get out of the chair. You're going to walk 10 meters and come back and sit down. I'm going to time that. Not only am I timing that, I'm looking to see if you're walking over to the left.
Right.
I'm walking to see if you walk in funny, if you're putting your heel down. Because what that's going to show me is how well you walk. And it's also going to let me know your risk for falling. Okay? And then when I watch the way you walk, I'm like, okay, you need a better heel strike. Yes, ma'am, you're drifting to the left. We need to get you back there. So that's a very good functional test. Everybody has to get up and walk. Everybody has to get up and walk fast, depending on what's happening. And so the goal is to get you at a particular speed, but a particular quality of gait. Gait, G-A-I-T, is the way you walk. I have to spell it out because the last time I said gay, the guy told me I was talking about gay people, but I want to clarify that. Okay. Single leg stance, balance. Can you stand for 10 seconds?
Like that.
Right?
Problem with that.
So 10 seconds. This is a test in my clinic. 10 seconds. And then 10 seconds with eyes closed. You all count for me. 10.
9, 8, 7, 6, 5, 4.
So I need some work, right? So I did that to show that even somebody who looks normal can still have those things. Okay. Why is that important? Because remember what balance is. Balance is muscle strength in the air and vision.
Right.
When you get up in the night and the room is dark, if you don't have your vision, will you still be balanced?
No.
So this sort of picks it up if balance is an issue, and then we start working and training you for that. All right, 30 seconds sit to stand. We can do that later. Diaphragmatic breathing, that's a big thing for me.
Yeah.
It's big because movement begins with the breath. The first thing that you did when you were born was what? The last thing you do before you transition will be? Breathing is important. So if you're not breathing properly, getting the oxygen in, a lot of stuff is going to be happening. We're going to deal with that later on. Lymphatic pump is going to come, and we're going to come back to that. And then a quick lymphedema screen. What does your arm look like? I'm going to grab your arm, I'm going to grab your leg, I'm going to poke you and see what that looks and feels like. Because we so used to being puffy and painful, we can't even tell when something is going on. All right, next slide for me. Boom. Case start. Well, we had case studies all throughout. So you see, entered the treatment stronger than thanks to prehab. We screened number 4. Through surveillance, we identified early swelling and addressed it quickly, preventing long-term lymphedema. She returned to gardening and regained confidence. Good. Next slide for me. Boom. Confidence in your health. Physiotherapy equals prevention and surveillance and survivorship support. So you see what happens first? Prevention, education, what we're doing now, surveillance, the screening aspect of it. Then we have the survivorship support, which is the intervention treatment. Boom, you deserve to feel strong and steady and confident in your body. This is the only body you have. You got to ride this one to glory. We can make this ride good. All right, next slide. Okay. I was trying to figure out how to get all of those in, so hopefully you can read it. But this is the way that physiotherapy supports. I'm visually impaired. Let me come on this side so I can read this for you. Good. Restores movement, freedom, helps you regain flexibility and range of motion. After surgery, radiation, and chemotherapy, reduces pain and stiffness, uses targeted techniques to ease discomfort and release scar tissue and soften tightness, rebuilds strength and energy, personalized exercise to build muscle, fight fatigue, and restore stamina. Personalized. Everybody's exercise program looks different. Reduce fall risk by retraining your body. Yes, we can retrain your body. That's what I need you to pay attention to feel steady. Support your bone and joint health. Mom talked about osteoporosis and joint health, so see, I have that covered. It was demo me. Protects against osteoporosis and joint weakness caused by hormonal changes in treatment, i.e. menopause, and some of us being pushed into premature menopause because of the drugs. Prevents and manages lymphedema, early detection, education, and gentle lymphatic techniques to reduce swelling and protect long-term function. Because my job is to make sure you keep doing what you need to do the best way you can do it without pain, swelling, numbness, tingling, and all of those other things. Address neuropathy and numbness. Helps to retrain nerves, improve circulation, restore sensation in hands and feet. We can retrain the nerves, we can improve circulation, and we can restore circulation in hands and feet. boost emotional well-being. Because if we ain't having fun and we ain't happy, what's the point?
Right.
Don't give me quantity of life if I can't enjoy it, right? So we're gonna have a good time doing all of this. Movement therapy reduces stress, anxiety, fear, and the reoccurrence whilst restoring confidence in your body. Promotes whole body healing. I did not talk about the part that they cut and what's missing. I talked about the entirety, from your head top to your foot bottom, as we say in Jamaica where I was trained. Incorporates breath work, posture correction, and integrative approaches to support mind, body, and soul. We had a great conversation on posture earlier this morning. Empowers you with tools for life and teaches practical strategies and safe exercises that you can use at home, allowing healing and continued beyond the clinic. Nothing I said I ask you to buy any equipment for and tell you need to do this particular technique and all these things. If I mentioned anything, it was making sure that you take note of the tests that you already paid for and already have access to. So you need to call up the last lab, the last doctor's office, and get your most recent test. Good? All right, next slide for me, please. Bang, that's module 2. We will cover that. We did a lot of that already. But boom, that's where we're going from here. Thank you very much.